So I'm very happy that you started out, Sandra, because what I'm going to talk about is the way we developed ours, and it's you have a lot of different things going on from your van, from your outreach. And we actually focused very much on healthcare from the beginning, and then began to interact with all the other parts doing harm reduction and health work in different settings. So our team was actually began 4 years before the team really opened, because we had a small project with health outreach in Copenhagen, looking at severely marginalized drug and alcohol users all over the city. And we had more than 500 persons coming through that project over a period of almost 3 years. And I saw around 100 of those, and made a thorough medical examination of each of those persons, and got all I could of medical charts and the disease history. And actually we had a very close view on the different problems that these persons have. So a lot of chronic somatic diseases, addiction problems, and psychiatric comorbidity, and chronic psychiatric problems. And we looked into their use of the healthcare system, and could see that they had a lot of interaction with the healthcare system, but not with the primary doctors as they were supposed to have. So what came out of that was actually that we thought maybe there's something wrong with the GP, with the general practitioner, because nobody wants to see the GP, and they all had a very low affection for the GP. But me as a GP didn't have any problems with the interacting with people, because I went out where they were actually at. So what we did was creating a health team in May 2005. In the beginning, it was me and 4 nurses doing outreach. And it was clear from the beginning that we had to interact with everybody doing social work in Copenhagen to actually have a space to be in. So we would go out for the first couple of months and introduce ourselves and say to people, well, we are here. We can do health work in your institution, your day center, your night shelter, or whatever. So we'll leave our phone number, and you can just call, and you'll see a nurse as fast as possible. And we set up some ground rules for interaction, which was that if you called a nurse, you were supposed to be seen to see the nurse within 7 days, and the patient was supposed to have treatment within another 7 days. And after a year, we made an assessment, and actually we always saw people at least the day after, and most people were treated the same day. So we overperformed happily. What we also see is that the people the basic population of health team is people who have been in addiction and homelessness for quite some years. They are normally from 35 to 60 years old, with an average of 44 for the men and 41 for the women. We have an 80-20% men and women population, as in almost every setting. We have a special population in Denmark, which is the Greenlandic population. The Greenland is a part of the of the Danish kingdom, so but with their own local government, but you can travel freely from Greenland and to Denmark and back again. And we see a lot of people with social problems back home who end up in Denmark with and some of them ending in the streets. We also have a very large Greenlandic population without any problems whatsoever, but some of the social problems in Greenland end up in the streets of Copenhagen. So actually, when you count the number of Greenlandic people, you have a 36 times greater risk of becoming my patient when you are born in Greenland than if you are born in anywhere in Denmark. So what we set up was we abolished the clinic. We didn't want to have any heavy stuff with us except a backpack. The first thing we did was to set up the network. Everybody who would like to play ball with us, we would play with. And then at that time, we had an outreach social work, which we saw as our closest partners. So what we also had from the beginning was a special GP number, which is the access to the healthcare system. So as a GP with that number, you can send people into the system for examinations directly, and we would then use all the partners we have, and the nurses would follow people into the healthcare system to have treatment done. What we also can do is, as part of the Copenhagen City Health social system, we can start basic addiction withdrawals and withdrawal treatment, and we can start any treatment we want to, very close to the individual. What we also has done from the beginning is that if you're in need of medication, you should have it, and we know that people will, at least in Denmark, we have to pay for the medication, so people wouldn't go to the pharmacy to pay for their medication. So we buy the medication and give it for free directly to the patient. Over the years, we've also gotten an electronic patient record, which on a mobile PC can be used immediately with the patient. So records can be put into the system, and we don't have to carry around papers and having problems with the GDPR system. We can also we are still expanding on the number of paraclinical things we can do. We have been doing blood sampling and sending it to the hospital system for since we opened up. But and right now we are expanding with a mobile EKG, electrocardiogram, and lung function system. So it will be very easy to do health outreach and actually do the treatment and the diagnostic procedures on the spot. What we also try to work with is to reintegrate people with their general practitioner. So from the beginning, it's not usually very easy. People don't have any confidence in the GP, or they don't want to go there because it's not a setting very good for people who might be in withdrawal or might have problems with getting a bath before they go there. So it can be a very stigmatizing thing to sit in a doctor's waiting room, and people would rather be sick than actually sit there. So the people we see 80%, 94%, 91% of our patients don't know or don't use their GP for various reasons. So we step in as the GP. That means also if you, for instance, if our social system needs doctors, papers from the doctor proving that the patient can have a pension, for instance, we can fill out those papers because we have this GP number. And that's making things very much easier for people. So we can actually take a full GP practice into any place we want to. So the basic idea was that this is the Danish GP system. You go to your GP, he sends you to a specialist, you go to a hospital, or you get your problem solved in the GP practice. And then you come back and get your medication and your prescriptions filled and whatever. And maybe so he'll take care of your need for healthcare. What we could see in our own system was that this GP was not there. So actually people went directly to emergency rooms to get their healthcare from them. But that system is not very good at communicating with people who are not stable. So most of the treatment was just done when people were actually in the emergency room and nothing was followed up, especially because much of the care started in emergency rooms is supposed to be taken up by your GP. And if you don't have any access to your GP, you won't get that treatment. So that's what we thought we would just turn this system 180 degrees around and go to the patient with the social work. So the social outreach worker, whatever it might be in a NGO clinic, it might be in a daycare center, night shelter, anywhere. There will always be somebody doing social outreach, and they will be the ones who will actually contact us, and they will start to find out how to get the person's economy running, and we will get into that and do the GP service from that space in cooperation with the patient and the social outreach. That's the basic idea, and actually it's very cheap and very easy. It actually came out of, I was watching a video in Vancouver with the street nurses of Vancouver, and I was struck by how much time they actually used to try to find a doctor. So I thought, well, maybe we should just take the doctor out of his clinic and send him around because he's easier to move. It was me from the beginning, and I like to bike, so that's what we did. So this is the system. If you look at the top, we have the normal GP system. You go to your general practice, you have different accesses to treatment. If you are, for instance, have an alcohol use, alcohol addiction, and we duplicated that in the, as you can see here in the bottom, and we used all the different institutions and NGOs working in that. Bottom here, it's the nurse clinics and street outreach and so on, and we have inpatient drug and alcohol treatment, and actually what we try to do is to integrate people into the normal healthcare system. But how long it takes will actually be, it will be the patient who decides how long times things will take. So the specialized systems, we approach the specialized systems from our side, as the GP will go to the specialized system from their side. So actually we are just doing exactly the same work, but from a different perspective. So what we have here is our lever blown up. We have the Copenhagen City addiction treatment, and they have different kinds of long-term in and outpatient treatment. And we have long-term housing for older drug users and older demented alcohol users. And they are actually, as it is now, a part of this Copenhagen social system where we are at. So they are close. We have a close cooperation with those institutions also. Yeah, so at the bottom we have the street outreach and the nurse clinics. And so if a nurse clinic needs a street nurse to take over a patient, they can just call the nurse and she will meet the patient at the clinic and they will plan how to continue. And they will, at the same time, the medical doctors of the team are servicing the nurse clinics. So they will actually continue to have the social, the same doctor as they had in the clinic, follow them into their housing or whatever. Yep. So we do outreach at different spaces. This is from Christiania. It's a nice morning picture. And this was a guy living in an old garage. That's how it looked inside, and treatment and social outreach starts here. So the nurse would go there and try to find out what he wanted, because we cannot, well, if needed, we could get people forcibly admitted to psychiatry, but it very seldom happens, because if we do that, we lose the confidentiality of the patient and they will not see us again. So we only do that when it's absolutely necessary. We don't have many street or rough sleepers in Copenhagen. We have some in summer. We have migrants, mostly from Eastern Europe, and they don't have access to more than acute healthcare in our system. So they can actually access our treatment system via the clinics or via one of the street nurses. We do regular health outreach days where we go into different institutions and do blood sampling, have talks about health, and try to follow up on everybody, trying to get people to hepatitis and HIV and treatment for whatever diseases they might have, and we try to follow it up over the coming years. Yeah. So some of the work is on bike, some of it is in car, depends on who the nurse is and where they go. What happened over time, 8 years after we started out, was that we really began to integrate the work we had done in the beginning with all the first line systems and second line systems in the city. We have more than 70 different NGOs doing homeless work. And we try to integrate with those as quickly as they come up. We just go there and say, well, here we are. You can use us for whatever needs you have. Mostly they want us to come and sit at specific days, and very quickly find out that it's a waste of their and our time. So they just begin to call us whenever it's necessary. And sometimes we just continue to have these fixed times when we have some kind of on-site nurse clinic or have the doctor coming there. What's come up over the years also is the work with peer organizations, and we have a very good relation with our local homeless organization called SAND, S-A-N-D, and the Drug Users Union and the Drug Users or the Users Academy, where we do health outreach those in these days. So this is the system. That the thing is that we have different clinics inside our part of the Copenhagen social system, and but the health team is the one providing healthcare for a lot of these institutions. They have their own. They might have their own nurses. For instance, we have the men's home, which takes care of our 2 drug consumption rooms, have a street clinic, which was started out as part of our system, but went to the men's home in 2010. But we have continued to provide medical service doctor service to that institution from the beginning in 2010. Or no, 2008 it was actually. But now we simply have this kind of system where the doctors from my team go to the different clinics and provide medical service for that. So it's spread all over the city. We have different shelter clinics. We have 3 very large shelters in Copenhagen. They all have a nurse clinic manned on a daily basis by nurses working there, and then I or one of the other medical doctors will come there and be on site 1 day per week, and then we are on call the rest of the week. So we will get in and out of those clinics as needed, but we'll have a fixed day where people know that there will be a doctor. We also have a podiatrist working in the street clinic in the city center, and she's very much used by everybody to actually get people from other sites in Copenhagen to have their feet taken care of. She's very good at diabetic feet and feet with neurological problems. We have social case manager in that street clinic, and we have the 2 drug consumption rooms also in the city center. In the southern part, we have a dental hygienist, which is going on pension this month. He has been a good addition to what we do, but from next year we'll have a better cooperation with the city dental service. So we just laid out the base for this. And then we have our national naloxone project, where we actually train staff all over the country to train others, to train the drug users in the use of naloxone. So we are rolling that out this year and next year. We have a small inpatient ward with 8 beds, which is open 24/7, and we have a collaboration with the Red Cross, who has an intermediate care institution where you can stay up to 14 days. They have 1 nurse, and a health team is taking care of the medical service of that. Then we, from time to time, see volunteer health staff coming up. Mostly they are active for a year or 2, and then it's kind of fades out. But as soon as they're there, we try to interact with them and get them to remit patients to us if necessary, or at least to work with the street nurses and when they come at the different centers where they base themselves. One thing that has come up in the latest years is that the local hospital system has made a setup of what they call social nurses. It's nurses working with homeless and drug users in the hospital system to try to provide a better healthcare. And almost all of them, as it has come, have been part of our system before they go into that. So they have all their phone numbers with them and actually interact very much with the nurses in the different clinics and in the street team. Yep. So as it is, we have this loosely knitted system where everybody can talk to everybody. They don't have to go through their managers. They can, anybody in a clinic or in a day center can call a nurse, and that nurse will then interact with the other health staff in this system. But we also have a lot of different um, institutions where people then actually work, and we just go in there and become part of those institutions when we are there. But you cannot be fired by a manager because you don't apply with what he thinks should be done, because they will all be in my team, and I have the final say on that. The best thing is that we actually now we are open 24/7, which means that you, in this system, you can see a nurse at any time, any day. Yep. See what works here. Nothing works. Yeah. So this is a bit of a busy slide, but it's actually, when I heard the first presentation, I thought, well, this is first line going into the second line, and we work there as consultants. Are we getting close now? Whoop. All right.